It's been well established that miniscrew implants provide orthodontists with greater anchorage control and more orthopedic treatment options. The problem is that miniscrews often fail, especially in the mandible, where the bone is denser. Pilot holes have been suggested to prevent such failures. We know that pilot holes during insertion decrease torque, and theoretically, lower insertion torque should reduce the strains within the bone. And that's good, because that should have a positive effect on both primary and secondary stability. Since the dynamic relationships that exist between the bone and the miniscrew hadn't really been well studied, our purpose when doing the study was to evaluate the effects of pilot holes on miniscrew stability and to determine whether the effects can be attributed to the quality and quantity of bone surrounding them. We used a randomized split mouth design in skeletally mature foxhound dogs. We compared miniscrews with pilot holes on one side of the mouth to those without pilot holes on the other side of the mouth. Uniquely, we were able to measure the stability of the implants longitudinally. We measured them each week for 7 weeks. We used micro-CT to quantify all of the bone around the miniscrew. We were able to quantify the bone between 6 to 60 microns away from the miniscrew surface. All of the screws remained stable throughout the study. Initially, the miniscrews inserted with pilot holes showed greater primary stability than those inserted without pilot holes. However, the stability decreased significantly more over time for the miniscrews with pilot holes than for those without pilot holes. In addition, the miniscrews placed without pilot holes had significantly more bone surrounding them at the end of the study, at 7 weeks. This was especially so for the trabecular bone. In other words, pilot holes produced greater primary stability, but also greater decreases in stability over time, due primarily to less trabecular bone surrounding them. The greater overall decrease in stability that we observed over time suggests greater remodeling with pilot holes than without. And this is probably due to the damage caused by the drilling. The tight fit of the drill bit may not have allowed for adequate cooling, despite the fact that we used copious irrigation with saline throughout the procedure. Wobble and compression due to the application of pressure when drilling could also have been a problem. The clinical implication of all this is that if you think that pilot holes are necessary, they should be drilled by hand rather than by machine. This should minimize the potentially deleterious effects.